Good evening. Welcome all of you to the April 9th Board of Directors meeting of the Washington Township Healthcare District. It's good to see all of you tonight. Nice full house. Good to see you. If you'd stand and join me in the pledge. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Catherine, if you'd take the roll for us.
Director Stewart.
Present.
Director Wallace.
Present.
Director Nicholson.
Present.
Director Danielson.
Present.
Director Egan.
Present.
We'll, first of all, have an education session. Anxious to hear a presentation on advanced healthcare directives. I think it's a very important subject. I think by the response of the board, it's obvious none of us have them. So this is a good opportunity to talk about it. Advanced care. Oh, I'm sorry. Pat indicates that she has one. So I didn't mean to make an make an assumption there. At any rate, Nancy, if you could introduce her.
It's my pleasure tonight to introduce Paul Hoffman. Dr. Hoffman is president of the Hoffman Healthcare Group in Moraga, California. He's worked in the healthcare field for over 35 years. For the past 15 years, he's devoted a majority of his time to assisting hospitals and health systems with accelerating their performance improvement efforts and writing and speaking and consulting on ethical issues in healthcare. He also serves as an advisor to healthcare companies and also as an expert witness. In addition to various other appointments, he's held positions as Executive Vice President and Chief Operating Officer of the Alta Bates Corporation, Executive Director of Emory University Hospital in Atlanta, Georgia, Director of Stanford University Hospital and Clinics in Palo Alto, California. Following his residency in hospital administration, he began his career at the Massachusetts General Hospital in Boston. He's a fellow of the American College of Healthcare Executives, a past member of its Leadership Advisory Committee, and he coordinates annual ethics conferences for the college. He is co-editor of Managing Ethically, an Executive's Guide, which was published in 2001 by Healthcare Administration Press. A second edition, Managing Healthcare Ethically, an Executive's Guide, was published in 2010. He's also the co-editor of Management Mistakes in Healthcare, Identification, Correction, and Prevention, published in 2005 by Cambridge University Press. Dr. Hoffman currently serves on the American Hospital Association McKesson Quest for Quality Prize Committee, the Joint Commission's International Standards Subcommittee, and the board of MedShare International. He is a senior fellow of the Health Research and Educational Trust and the board chair of San Francisco-based Operation Access. In 2009, Dr. Hoffman received the American Hospital Association's Award of Honor for his central role in shaping the field's understanding of healthcare ethics. An author of over 150 publications, Dr. Hoffman has held faculty appointments at Harvard, UCLA, Stanford, Emory, Seton Hall, and the University of California. His Bachelor of Science, Masters of Public Health, and Doctor of Public Health degrees are from the University of California at Berkeley. And with that, I'd like to turn the program over to him.
Thank you for that nice introduction, Nancy. As some of you may know, I've had the privilege of knowing Mrs. Farver for many years, too many years for us to recount. And I've had the privilege of speaking to the board in the past, and I'm just delighted to be with you again this evening. This is a topic that it's difficult for me to be objective about because, like most of you in this room, death comes to our family and to our friends in unanticipated and sometimes unexpected ways. And so one of the reasons that senior administration has endorsed the proposal that the end-of-life palliative care task force has developed is that we know that this is an opportunity to remind people of a very difficult and painful topic. Most people don't want to talk about death. It's not the kind of issue that comes into normal conversation unless you happen to be in a situation where you are dealing with it on a day-to-day basis or perhaps episodically. And so this is an opportunity really to help educate the community. So my purpose in being here this evening is to talk a little bit about advanced directives. I think many in the audience are familiar with them. They sometimes go by different terms. And so what I want to do relatively briefly is to give a brief overview of advanced healthcare directives and describe why encouraging completion of these documents is so important, not just for patients, but for families, for the Washington Hospital healthcare system, and for residents of the district. And hopefully those reasons will become increasingly self-evident. So I would begin by pointing out that advanced directives have been around for a long time, at least 50 years or more. Historically, they've sometimes been referred to as living wills. At today's meeting of the Bioethics Committee, one of the members mentioned that he was reminded when he was doing estate planning that a condition that the attorney set for doing the estate planning was to make sure that this particular physician had an advance directive. So it was clear from this physician's point of view that attorneys, as well as others, are increasingly aware of the importance of having individuals complete advance directives, and preferably when they're healthy, not when they're in crisis. In 1976, California became the first state to pass what was then called the natural the natural it was Natural Death Act is what it was called at that time. And in 1974, I was the director of Stanford University Hospital, and I testified as the only hospital administrator in the state in support of the legislation. It took 2 years to pass it. But since that time, just about every state in the country has passed similar legislation. And then in 1991, a pivotal year, the U.S. Congress passed what was called the Patient Self-Determination Act. And that essentially required every hospital in the country that received Medicare or Medicaid funds, which was basically all hospitals in the country, to ask patients at the time of their admission whether they had an advance directive. Now, this wasn't a requirement that every patient have an advance directive, but it was a recognition on the part of the Congress that this was an important document. And they knew that most people would not be receptive to the government saying, you must do this. They were simply saying that hospitals should be engaged in helping to educate patients and their families. And so that was a major initiative that has had, I think, a significant impact. But the vast majority of Americans still do not have advance directives. More recently, in 2001, the California law was passed, which was called the Physician's Order for Life-Sustaining Treatment, that goes by the acronym POLST, P-O-L-S-T. And some people are understandably confused between what an advance directive is and what a POLST is. And essentially, a POLST is a document that is completed by a physician in consultation with his or her patient. So if and when he or she has a cardiac or respiratory arrest, for example, at home, the EMTs, the emergency medical technicians, are aware of what that person's preferences are if he or she has a cardiac or respiratory arrest at home. And that patient may say, I want everything done, or I only want some things done. So the POLST is really not for inpatients, but essentially for those people who are at home and are in an emergency situation, and they have an opportunity to say to their family, to their friends, and even to the first responders, this is what I want done under these circumstances. So the legislation that became effective in 2001 simply provides a legislative support for that important document. I saw an article not too long ago authored by a physician, and these are the 4 things he said everyone should know about end-of-life planning. And I thought it was so succinct and so insightful that I wanted to share it with you this evening. First, he said, know it's okay to talk about it right now. Don't wait until you're sick or injured. Because this is an uncomfortable topic, most people tend to put it off. And so what he was saying is don't put it off. Talk to your family, talk to your friends, sign an advance directive yourself. And probably, at least in my view, one of the most important elements of an advance directive is the opportunity to designate who you would want to speak on your behalf should you lack decision-making capacity. And that decision-making capacity loss may be either temporary or it may be permanent. But the important thing is to think well and candidly and in consultation, hopefully with your family and or friends, who would that person be who could best represent your interests. And the reason that's so important is that, as I'll mention later, a lot of the ethics consults in which we become involved here at this hospital involve controversy or disagreement among family members because a patient doesn't have an advance directive and hasn't designated who he or she would want to speak on their behalf when they cannot. So what is being emphasized here is know who your healthcare proxy should be and speak to that person about what your preferences are should you be unable to influence decision-making regarding treatment modalities. Third, know you can change your mind at any time. It's easy to select another proxy and or treatment options. There is a false perception that once you sign an advance directive, that it's immutable, that it's irreversible, and that's simply not true. You have the prerogative at any time to say, rather than my brother, I want my sister, or I want my daughter or my son to speak on my behalf. And whereas in the past I've decided that I don't want certain treatment options under certain circumstances, I've now changed my mind. And that can be done at any time, literally at any time. And then fourth, know to ask questions. Speak to your physician and to your family. So what's the value? I think it's compelling and it's irrefutable. I think the most important thing, as I've already indicated, is that it really documents your choice, your preference for who should be speaking on your behalf when you cannot communicate. Secondly, it provides clear direction regarding a person's preferences regarding treatment decisions near the end of life. Now, we know that in the past, politically, there was a lot of conversation about these so-called death panels. And I abhor that kind of language, and I'm not speaking from a political point of view. I'm simply saying that an individual has the prerogative of saying, I want everything, I want something in the middle, or under certain circumstances where I know that I cannot recover to a reasonable quality of life, that I only want pain and symptom management. I only want comfort measures under these circumstances. So this does not dictate what your choices should be. What this does is it lays out the options and encourages you to make an informed choice in conversations with your physician and with members of your family. And as I've already indicated, you can change your mind at any time. So what are the benefits? One of the most basic principles in bioethics is the principle of autonomy, the right of self-determination. And what this does, it provides clear and explicit direction that gives you an opportunity to say, this is what I want, so that family members and healthcare providers don't have to speculate. They don't have to guess. Just today, we had an ethics consult at our bioethics committee meeting, and the son of a patient came and spoke about his concerns, and his, in this case, the physician of the patient was there as well. Obviously, for reasons of confidentiality, I can't provide specifics. But the fact of the matter is that there is a process that works well here at Washington Hospital. And I think the board is to be commended, as well as senior management and the medical staff, because the staff here understand and support the basic principles that are so important when it comes to this particular issue. We know from our past experience that when patients and families have the opportunity to discuss their preferences, that their level of satisfaction with the healthcare organization and healthcare providers is higher. Thirdly, we know from past experience, not only here but around the country, that when there is clarity with regard to patients' preferences, there are many less conflicts. It doesn't mean that all conflicts and dilemmas are prevented and avoided, but we do know that when there is clarity about a patient's preferences with regard to who he or she wants as his or her surrogate decision maker, and what he or she would prefer among treatment options, that the likelihood of ethical conflict and ethical dilemmas is much reduced. It is true that on occasion there may be a reduction in costs and the reduction in the inappropriate use of invasive procedures, but that is a side effect, if you will. That is not the purpose, that is not the goal, that is not the objective. The objective is to do what is in the patient's best interest. So what's the rationale for getting your formal endorsement as board members? We believe, that is, the End-of-Life Palliative Care Task Force believes, and this is, I think, been a consistent commitment on the part of the task force, that if the board, with the support of senior management, says, yes, we believe that this initiative is sound and in the best interest of patients, family, and the community, that we ourselves, as board members, will sign advance directives. We will take the lead. We will be an example to the community, because we believe that if every board member, every member of management, every employee, every member of the medical staff, every volunteer signs an advance directive, that he or she will be that much more of an effective advocate when they talk to their family and to their friends, because they will be more knowledgeable, so that you can act as advocates, as effective ambassadors. And I think perhaps as important, Washington Hospital will demonstrate its community leadership in addressing a critical issue. Now, there is a document that will be distributed to you if it hasn't already, that it's a timeline. So what we are doing as part of this process, we have developed a comprehensive timeline that begins with a submission of the proposal to Mrs. Farber and her senior management team to see if there were support for the proposal. And we did get a positive response. That then resulted in scheduling this presentation to the board with the hope that the board will endorse the program. There has been preliminary conversation with the medical staff. So our hope is then that the medical staff will replicate the support of the board. And then there is, on the 17th, next week, a national day for promoting the completion of advanced healthcare directives. There will be a series of programs presented here at the hospital. We then will be meeting, as we do on a monthly basis, with our task force to develop specific metrics to measure our progress over time. So we know that this has to be a concerted, systematic effort, and to reach out into the community, to have educational programs, to reach out to the various ethnic groups, to go to mosques, to go to synagogues, to go to churches, and to engage the clergy, so that ultimately we would hope that we could emulate La Crosse, Wisconsin. And you would say, well, why would you want to emulate La Crosse, Wisconsin? Gunderson Medical Center in La Crosse, Wisconsin, by virtue of its institutional leadership, has gotten over 90% of its citizens to complete advanced directives. And so they are the national poster child, if you will, for how this could and should be done. So we are not disinclined. We are, in fact, inclined to say, okay, what are the best practices in this area? What can we do that has been proven effective in other communities? And so, fortunately, because of Mrs. Farber's support and the encouragement of the medical staff, we believe this is an issue that can and should be addressed in a very comprehensive and systematic way. And with your support, we hope to do that. I'd be glad to answer any questions if any of the board members have questions.
Any questions?
Yes?
Yeah. What's your recommendation as to where you file these directives and you know?
So the question for some of you who may not have heard it is, well, where is the best place to file this document? I think that it's important to keep it with other important legal documents. I think that if you have an estate planner, he or she should have that document. I think the person who you select as your surrogate decision maker should have the document. If and when you are admitted to this hospital or any hospital, they will be asking if you have an advance directive. And if you do, they will request a copy. And it will be placed in the electronic medical record, not only for that current admission, but for subsequent admissions. So it'll be on file here at the institution. And if and when, however, you want to change it, as I said earlier, you have that prerogative.
Dr. Hoffman, thank you. This has been a long-time passion of mine, and most of this information I'm well aware of. The problem that I have had throughout the years is the documents that are used. There's been some documents where the doctor was supposed to complete it, and they, with much going after them and running down the halls after them, we did get them to sign the document totally blank, which is not appropriate. Then the Pulse came along, and it doesn't quite fit the bill either. There's major issues with it that I can see. So the question that I have for you is, this material is absolutely great, and I'm in 100%, 110% favor of what you're doing and want you to go forward with it, but it's the document itself that I'm hung up on, because the 5 wishes, I tried to complete that document and I absolutely ran into a brick wall. It's not important for me whether the blinds are open and closed when I'm dying. But to some people it is. But it's so long to get through it, you lose yourself in the minutia in that document. So are you going to be developing a document? Can we expect one? Do we write all of this information out narratively? Where do we go with getting it on paper?
Those are a great set of questions, and there's no simple answer. We will not, to the best of my knowledge, try to redesign the advance directive. I think the answer to your important question is that when it comes to specifics, I think the important thing is to talk to whomever it is that you've designated as your surrogate decision maker, because you're quite right that some of the forms and some of the language is either indecipherable or is very difficult to communicate to others. And I didn't bring with me, but I have on my desk a set of cards, literally a deck of cards, and it's a set of wishes. And it says, you know, these are the things that are most important to me. I don't want to die alone. I don't want to die in pain. I prefer to die at home. I want to have a member of my faith with me. And there are about 20 or 30 of these cards. And it is a fascinating exercise to go through on an individual basis, because each wish is very clear, very simple. It's a way for you to think clearly and coherently about what is most important to you when you are near the end of life, which no one enjoys talking about. But the default position can be hellacious. And I think that's what we want to avoid. We want to make sure that if a patient says that he or she wants everything to the very last minute, that they have the prerogative to make that request. There may be a point at which non-beneficial treatment no longer makes sense. But if the patient wants every conceivable invasive diagnostic and therapeutic intervention, that's his or her prerogative. But alternatively, and this is true of an increasing number of people, the vast majority of Americans do not have advance directives. And yet the vast majority of Americans think that people should have them. So we still have this dilemma. So you are quite right that all the documents and all the forms can seem overwhelming. So my advice is do your best. And most importantly, complete what you have, and then talk to the person who is going to be representing your best interest if and when a crisis occurs.
I like your card idea, because it seems like you could have your deck of cards, and if you change your mind, you can pull that card out. However, the medical record side of me kicks in and says, when there's 10 cards and if you've numbered them, how do you know that one is missing? So you'd have to think about that as well, and somehow make sure that somebody didn't take out the card or accidentally got
lost. And I
lost.
wasn't suggesting that the cards become part of the formal process, but rather as a vehicle to help facilitate the conversation. So I understand what you're saying. Yes, we cannot imagine cards becoming part of the electronic medical record, but we can think of those cards as a way of saying, look, this is a difficult conversation, but I think it's important to have it, and these are the things that I think, in terms of priority, are most important to me if and when I should be in a situation when I can't speak for myself.
Thank you.
Thank you.
If you're interested, I have several decks of those cards in the administrative office.
Great. It's a hard decision to make, and I like the phrase of non-beneficial treatment, because with the way healthcare is going and the developments constantly, people can be kept alive after they're not alive.
Well, thank you for that observation, because again, Washington Hospital has been very progressive in this area. The Bioethics Committee reviewed and recommended the support for a non-beneficial treatment policy, and it's been approved by the medical staff. It's gone to the Medical Executive Committee, and I believe it's been endorsed. So there is a process in place which provides for engagement and involvement in these difficult decisions, and a procedure to follow if and when there is that determination made that further intervention will, in fact, from a professional medical point of view, no longer benefit the patient.
Dr. Hampton. I think it's important that we start with a full deck of cards. And that's important, and I mean that from a number of aspects. One is that the conversation is had when people have the faculties to make that decision, to make these decisions. And second, that the deck of cards really is reflective of the full palette of options that we have in deciding our end-of-life care. I share some of Director Danielson's concerns about the adequacy of the documents. And I was wondering if you could make a comment as far as what is more important, the conversation or the document. And if it is indeed the conversation, which is the crux of resolving this issue, are there video resources, YouTubes, or places we can go to watch how a conversation might take place and to learn from others who are going through this process?
Two questions that you've raised. One is which is most important, the conversation or the document, and they're both important. I think I would put first and foremost the conversation. And secondly, the decision about who your surrogate decision maker is. Because the conversation about what your treatment preferences might be is important, but it's less important than the first two. That is the conversation and the designation of the surrogate. With regard to your question about video and other material that's helpful in facilitating and promoting the conversation, there is in fact a conversation project that is supported by the Institute for Healthcare Improvement. Hundreds of thousands of people have participated in the conversation project, and there are indeed videos. And we will be sure in the resources that are made available that the links to those videos will be made available so that those people that have the time and the interest will be able to access them.
Great. Thank you.
Thank you very, very much. It's always a
Thank you.
pleasure to have you here, and your presentations are always very, very fascinating.
Thank you, sir. I appreciate the
Appreciate
opportunity.
your work in this area. I have a very, very personal feeling about this right now. My brother passed away just a month ago, and it turned out that I was the decision maker. And those times cannot be more stressful. I just can't emphasize enough how difficult it is to be in one of those situations. But because of training I had received here, because of things I've learned, it was made much easier. And I admit tonight I don't have an advanced care directive. I've already said that. But one is open on my desk at home. And besides that, I have committed to assembling my family. I have 5 children, and we're going to get together and we're going to talk about this kind of thing. Because I feel in some ways as though, having been through that and the death of my father not long ago, I feel somewhat expert in the field. And yet, it's a conversation we need to have. And I appreciate your words tonight.
Thank you. Well, let me express my condolences. And I don't know whether you feel, as chair, that it's appropriate to ask for the board's endorsement. I defer to you and to Mrs. Farber. But what we would hope is that we can provide a signal to the hospital community that this is an important enough program that there is, in fact, board support. But I certainly defer to you. But thank you again for the opportunity to be here.
Thank you. I think we can express that support. I think there's unity on the board tonight to express our support and our backing for that. And I will get mine done. Thank you again. We'll now go to our consideration of minutes for March 12th, 17th, 24, and 26th of this year.
Move for approval?
I have a motion
Second.
and a second. Any discussion on those at all? All in favor, we need to do that by a roll call vote. So Catherine, if you would do that, please.
Yes. Director Stewart,
Aye.
Director Wallace.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Aye.
Director Epen.
Aye.
That motion passes. We now would be open to any oral communications this evening. We have received no cards for that. Seeing none, we'll move now to our written communications. Dr. Lunny, our Chief of Staff.
I'll report the medical staff credentialing action items for March. We had one new appointment, Dr. Richard Kurtek, Emergency Medicine. For reappointments, we had Dr. Bala Anadurai, Internal Medicine, active. Dr. Andy Chang, Family Medicine, ambulatory status. Dr. Jason Chang, Radiology, active. Dr. Susan Shu, Family Medicine, ambulatory status. Dr. Mimi Lin, Radiology, active. Dr. Reza Malik, Radiology, active. Dr. Gabriel Miranda, Family Medicine, active. Dr. Lily No, Pediatrics, ambulatory status. Dr. Thomas Steckel, OB/GYN, active. Dr. Vivian Sai, Cardiology, active. Dr. Nitin Verma, Pediatrics and Sleep Medicine, ambulatory status. And Frederick Wilson, Podiatrist, active. We had one physician who did not engage in reappointment, so is deemed to have resigned, Dr. Patidar. And two physicians who completed proctoring and advancement in staff category, Dr. Elizabeth Arias, Internal Medicine, going from provisional to active, and Dr. Vivian Sai, Cardiology, going from provisional to active.
Second.
Motion and a second. Any discussion? Again, Catherine, if you could call the roll for... Aye.
Director Wallace.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Aye.
Director Epen.
That motion on the medical staff reappointments is passed. We'll now move to our hospital calendar. It's presented
We'll
both
start with the video.
video and by Ms. Farber. Oh, I'm sorry. Gail, I apologize.
And you skipped Gail.
We won't start with the video.
You know,
He's still thinking about the advanced grade.
you're all shook up.
That's right. Gail, I sincerely apologize.
That's okay.
You are on.
Well, this week, April 6th to the 13th is National Volunteer Week. And the Service League would like to acknowledge the cards and treats that we've been receiving from staff, doctors, and others. And we really appreciate their good thoughts and have been enjoying the treats, so thank you very much. Once again, we are having our $5 jewelry sale at the end of the month. So it'll be Monday and Tuesday, April 28th and 29th from 7 a.m. to 6 p.m. and on Wednesday, April 30th from 7 a.m. to 5 p.m. It'll be in Washington West in Auditorium C. There will be a display of fine items just in time for Mother's Day, graduation, Father's Day, teachers' gifts, and et cetera. There's new items every day, so come by and please tell your family and friends, and we'd love to have you. This is a fundraising event for us, and it's sponsored by the Service League, and all the proceeds benefit Washington Hospital.
Thank you, Gail. I can speak to the jewelry sale. This is a $5 time.
And this is one of the necklaces?
And this is,
I have a question.
go ahead.
You still have the valet parking for the event, correct?
Well, hopefully, yes.
All right, okay. So people can use the valet parking,
Yes.
so they don't have to carry their bags of items all the way out to their car, just a shorter distance, right?
We
Great.
will make sure that we have valet parking.
Okay, great, thank you.
Normally, these would be $20.
Well, it's good, those are good items.
And it's, I think it's a good time. Anyway, thank you again, Gail, and I apologize for skipping. Now, to the medical staff report.
We currently have 505 members of our medical staff. 26 are in the Department of Anesthesia, 47 in Family Medicine, 199 in the Department of Medicine, 35 OBGYN, 60 pediatrics, 27 radiologists, and 111 in the surgery department. We currently have 46 medical staff members in the application process, 36 with full applications, and 10 with pre-applications.
Thank you. Now we can have the video.
All right.
Much
We'll do the
anticipated
hospital
video.
calendar video.
Past health promotions and outreach events. On March 18th, Dr. Mark Saleh, urologist, presented Prostate Health and Prostate Cancer. This event was co-sponsored by Washington Township Medical Foundation. 63 people attended. On March 19th, as part of the Women's Center Healthy Knowledge at Noon programs, Lori Roffelson, registered dietitian, presented Snack Attack, Healthy or Harmful. 17 people attended. On March 22nd, Washington Hospital hosted Stroke Awareness Day. This free event screened community members for carotid artery blockage, atrial fibrillation, as well as cholesterol, blood sugar, and blood pressure screenings. The event was staffed by Dr. Ashjane, cardiologist, who provided results, interpretation, along with Washington Hospital personnel. Volunteers from San Jose State School of Nursing and the Washington Hospital Service League also assisted to make this event a success. Fremont Bank co-sponsored this event and provided refreshments for the attendees. 130 community members were screened. Of those 130, 4 were found to have blockages, 8 were found to have atrial fibrillation, and 11 others were found to be at high risk for stroke based on other risk factors. On March 24th, as part of the Women's Center Healthy Knowledge at Noon programs, Carrie Robertson, kinesiologist, presented on osteoporosis and women. 31 people attended. Washington Hospital celebrated National Doctors Day on March 28th by hosting a luncheon for members of the Washington Hospital medical staff in the Anderson Auditorium. The event was the organization's way to recognize physicians for their service and commitment to their patients' health and well-being. Approximately 120 physicians attended the event. On April 1st, as part of the Stroke Education Series, Dr. Ashjane, cardiologist, and Doug Van Houten, RN, presented Acute Management of Stroke and Chronic Care and Stroke Rehabilitation. 42 people attended. On April 3rd, as part of the Diabetes Matters Education Series, Kevin Bronson Castaigne, RN, presented Diabetes Disaster Planning. 14 people attended. On April 5th, Washington Hospital participated in Operation Urban Rescue, a mass casualty training exercise. The exercise involved a mock bomb explosion with mass casualties at a festival held on the Unitech College campus in Fremont. The event also played out in a small area of the Washington Hospital campus. Unitech College, the Fremont Police Department, members of the National Guard, and Washington Hospital employees all took part in this drill. At Washington Hospital, the goal of the drill was to practice and assess the hospital's readiness in the event of a mass casualty disaster. National Volunteer Week begins April 6th. Washington Hospital honors and thanks all of the volunteers that help support the healthcare system, including the volunteer chaplains, Washington Hospital Employee Association Board volunteers, the Washington Hospital Foundation volunteers, and the Service League volunteers. Washington Hospital is fortunate to have over 500 men, women, college, and high school students who volunteer their time to help families provide support, answer questions, and help us provide the best possible care for our patients. Upcoming health promotions and community outreach events. On April 15th, Washington Hospital will host the 8th Annual Women's Health Conference. This event will feature such topics as thyroid health and prevention of thyroid cancer, varicose veins and vein rejuvenation, women and stroke, and finding the fountain of youth through exercise. Dr. William Degoni, Medical Director for the Washington Women's Center, will provide an update on the Washington Women's Center. This event is co-sponsored by Washington Township Medical Foundation. On April 15th, from 6:30 to 8:30 p.m., Christy Caracappa, Health Insurance Information Service Coordinator, will present Medicare, Are You Turning 65? On April 26th, Washington Hospital, in conjunction with the City of Fremont, will host the 2014 Go Green Together Earth Day event. The event will feature information on recycling and waste reduction, saving energy at home, and healthy eating. There will also be free residential drop-off of unused and unwanted medications, eyeglasses, and confidential documents for shredding. Kids can participate in fun activities such as the bike rodeo and face painting. For more information, visit www.whhs.com/green. On April 29th, from 6:30 p.m. to 8:30 p.m., Dr. Mary Maish, thoracic surgeon, and Dr. Arun Srivatsa, gastroenterologist, will present GERD and Your Risk for Esophageal Cancer. This event is co-sponsored by Washington Township Medical Foundation. On May 1st, from 7 to 8 p.m., as part of the Diabetes Matters series, Andrea Waters, RN, will present Insulin, Everything You Wanted to Know But Were Afraid to Ask. On May 2nd, from 2 to 4 p.m., Dr. Alexander Saw, orthopedic surgeon, will present Do You Have Knee Pain? Learn the latest treatment options. On May 6th, from 6 to 8 p.m., as part of the Stroke Education series, Dr. Ash Jane, cardiologist, and Doug Van Houten, RN, will present Stroke Prevention and Other Disease Processes and Healthy Lifestyle. Be smart and avoid stroke. The Washington Hospital Healthcare Foundation Report. The Foundation's annual golf tournament takes place in just a couple of weeks, on April 28th, at the Castlewood Country Club. Held in memory of longtime Fremont businessman Jean Angelo Pisano, the tournament promises a day of great golf and fun surprises. Proceeds from the event will support surgical services at Washington Hospital. The tournament is expected to sell out soon, so to reserve your foursome or to inquire about sponsorship opportunities, please call Washington Hospital Healthcare Foundation at 510-791-3428. The Washington Township Healthcare District Board of Directors Report. In the past month, District Board members represented Washington Township Healthcare District at the Indo-American Community Federation Unity Dinner on March 21st, the New Haven Schools Foundation Casino Night on March 22nd, the Alameda County Special Districts Association Annual Dinner on March 27th, the Fremont Chamber of Commerce State of the City Address given by Mayor Bill Harrison on March 28th, and the Citizens for Better Communities Spring Celebration on April 5th. Washington Hospital Employee Association, WIA. The Washington Hospital Employees Association is currently accepting scholarship applications for the 2014 Don Pickenpaugh Memorial Scholarship. Don Pickenpaugh was the longest-serving board member on the Washington Township Healthcare District Board of Directors. During his 27-year tenure, he served as board president 5 times. This $2,000 scholarship is available for dependents of Washington Hospital employees. The applicant must be presently enrolled as a full-time senior in a California high school or must be pursuing a degree as a half-time or more student at an accredited college, university, or vocational school. Applications are available for pickup in the Community Health Resource Library in Washington West or through the hospital intranet under the WIA heading. Completed applications must be returned to Christy Caracappa in the library by Friday, April 18th at 4 p.m. WOW! Washington on Wheels Mobile Health Clinic. The Washington on Wheels WOW! Mobile Health Clinic continue to serve community members at the Fremont Family Resource Center, the Fremont Senior Center, the Silliman Activity Center in Newark, the New Haven Adult School and Ruggieri Senior Center, both located in Union City. WOW also provided healthcare services to students and families at Breyer Elementary School and the Fremont Unified School District office. Internet marketing. Washington Hospital's website remains very active. The hospital's Physician Finder section was March's most viewed webpage with 15,101 views. InHealth, Channel 78. During the month of March, Washington Hospital's cable channel 78, InHealth, aired new programming, including the March Board of Directors meeting and a health and wellness program titled Don't Let Hip Pain Run You Down. InHealth also taped a Diabetes Matters program titled Diabetes Update 2014, What's New? Two health and wellness programs titled Do You Have Health Insurance Coverage? And Prostate Health and Prostate Cancer, and a Healthy Knowledge at Noon program, Snack Attack. Other updates. The Gordon and Betty Moore Foundation has awarded Washington Hospital Healthcare Foundation $100,000 to support Washington Hospital's work to obtain Magnet redesignation. Magnet designation, the highest level of recognition that a hospital can achieve for nursing excellence, is granted to healthcare organizations by the American Nurses Credentialing Center. On March 24th, as part of Unity Day, Washington Township Healthcare District Board member Patricia Danielson was recognized on the floor of the California State Senate for her 2 decades of service to the community. She was honored by Senator Ellen Corbett. On March 29th, Dr. Carmen Akawili, Medical Co-Director of Critical Care Services, was inducted President of the Philippine Medical Society of Northern California. The Philippine Medical Society is a philanthropic organization of Filipino-American physicians who provide much-needed medical, surgical, optometric, and dental services to their underserved communities, locally and abroad. National Nurses Week 2014 takes place May 6th through May 12th. This year the theme is Nurses Leading the Way. During Nurses Week, we celebrate nurses who every day step forward embracing new technologies, resolving emerging issues, and accepting ever-changing roles in their profession. They lead the way for their patients, colleagues, organizations, and the healthcare industry as a whole. National Hospital Week 2014 begins May 11th, and Washington Hospital will be celebrating the men and women who day in and day out support the health of the community through compassionate care, constant innovation, and unwavering, unmatched dedication. For more information on any of these programs mentioned, visit WHHS.com or call 1-800-963-7070.
Getting my eyes back.
Hospital golf tournament on the 28th. That's always a really fun day. It's a very, very nice day. This year it's at Castlewood. We'll have a really good time out there. The board participates in that. We have one serious golfer on the board, Mr. Wallace. The rest of us don't know exactly which end of a golf club to hold. But we are participating in the Whack-A-Duck program. And we have 2 ducks here, but in the tournament, the players will have an opportunity to play a little game with the ducks, and there's a prize and all those kinds of things. It's just indicative of the fun day we have out on the golf course. Invite anybody who wants to join us that day. It's a great, nice day to get out in the open. If the weather stays nice as it is, it should be a very, very good day. And the rest of those of us that are not as good as Mr. Wallace, do the whack-a-duck, and it's a lot of fun. Nancy?
Okay, I'm going to start with our Employee of the Month and then go on to a couple of other calendar items I wanted to mention. But first, let's honor Richie Patel. He's our Employee of the Month for April 2014. He started working for our hospital as a new grad in 2003. He worked in med-surg and in the Center for Joint Replacement as a charge nurse. Then he completed some ICU training and became certified as a heart nurse. And as one of the RN super users and also a perennial high achiever, he joined the Epic Build team. Even though his experience was med-surg and intensive care, he volunteered to be part of the emergency department ASAP team, as that was a big need we had. He's been a strong supporter for the entire Epic team and works very well with his fellow ASAP team members to ensure that all the ED nurses and doctors, and especially the patients, are receiving the support they need to make the Epic system run smoothly. More recently, we had a very short timeline to install Krame's education materials in the emergency department, and he worked the entire week of Thanksgiving, including the weekend, to make sure the install was successful by our November 30th deadline. This extra effort is an example of what makes him such a strong asset and a leader for the Epic clinical operations. He's always eager to learn new things and willing to share his knowledge with his colleagues. As a bedside nurse, he was known for being compassionate and a great facilitator between patient and family and the medical world. He is professional, accountable, and he takes pride and ownership in his work. He pushes himself to be the best at all times. He always has a positive attitude and is a pleasure to work with. His colleagues have said that Richie shows great leadership and is committed to patient care and is a great team member. So it's a very distinct honor to be recognizing him this month. I wanted to say just a little something about the flu epidemic. The Argus carried an article this morning about the flu epidemic that we've just, I think now are seeing the end of. They expect this flu season to be over by mid-May. And the majority of those younger than 65 who died in the last 7 months were between 40 and 64 years of age, and at least 7 were under the age of 18. The experts are saying the H1N1 flu bug hits younger generations harder because they often go without vaccination and may not have acquired immunity through previous exposure. We had an exceptionally high number of flu deaths in this past season, 355 people younger than 65, since the flu season began in late September. And that's at least 3 times the number of Californians in that age group who died in the flu season in the prior year. So the importance of vaccination needs to be underscored, and even though we're approaching the end of the flu season in mid-May, which is just weeks away, I think that it's imperative that we remember this when we start vaccinations for the flu season in the fall. I also wanted to talk about ICD-10. We've had a presentation here at public board meeting about this new coding system. The government has sworn up one side and down the other that there would be no extension in the date upon which we were supposed to be prepared to commence using ICD-10. They said under no circumstances would implementation be delayed, and then they decided to delay it, which has upset many in the provider world. Hospital systems have spent millions of dollars preparing for this. We've taken a look at what we have here because we were just days away from starting massive training of all of our physicians. And we think that 90% of the build that we did is relevant and can be conserved for when the government decides to implement ICD-10. About $293,000 of the money that we spent getting ready for this system is a dead loss. And I think that's pretty consistent with what's been projected, depending on the size of hospitals across the country. The American Hospital Association was making projections of about $250,000 to $450,000, depending on the size of the hospital. One of the things that's important for everybody to understand is that they didn't promise that they would implement it on October 1st in 2015. October 1st, 2015 is the first day that the government could consider making it operational. And probably what is all the more of concern is that the rest of the world outside of the United States has already started to implement ICD 11. So for the time being, this has been set aside. The training was canceled. And when the government decides to bring this forward again, we'll build that schedule and again try to get ready with the hopes that they'll actually do it. I also wanted to make sure that the board and our community was aware of an announcement that was made this week. The UCSF relationship with Children's Hospital has become a merger, and the Benioff family has made a $100 million grant to UC, and I think about $500 million of that is earmarked for Children's Hospital in Oakland, which is wonderful news for Alameda County, because that hospital was, I think, struggling and desperately needed this infusion of capital. It's wonderful, wonderful news, and I'm very proud to be associated with UCSF, and they really did step up and save that hospital for the Alameda County community. It's a wonderful thing. Last week, we had an unannounced mock survey as part of our preparation for the Joint Commission survey, which we expect this summer or early fall. It was a 4-day survey. The real survey will be 5 days, but in 4 days, we got a significant amount of information. And one of the things the surveyors said I wanted to repeat to the board members. They go to a lot of hospitals all over the country, and they were quite taken with how forthcoming our staff is, and that they aren't afraid to talk to surveyors or mock surveyors. And they were very impressed with the super users in the Epic system and their facility with the system and our staff's facility with the system. Very, very much impressed. And they went out of their way to compliment us on the caliber of Washington Hospital employees and their willingness to participate in the survey. They say most places where they go, the staff disappears and does everything they can to try to avoid visiting or talking with the surveyor. So I was very pleased to hear that. I also wanted to talk just a little bit about that disaster drill you saw pictures of. It started about 9 in the morning and went until maybe 1:30, 12:30, 1 o'clock, maybe in or around there. We had the California National Guard. We had the students from Unitech. The Fremont SWAT team was here. And the things that we learned were of tremendous value and importance to us. And we've learned that we have some dead areas on our campus where Fremont police radios don't work. I'm going to be meeting with leadership of the Fremont Police Department, and we're going to do a formal survey. And we will put repeaters where they are needed, because I believe that the Fremont PD may be needed to go just about anywhere at any given point in time, and we have to make sure they can maintain their communications. Dead spaces are created by things like lead walls and radiology that protect everybody from radiation, but also in the tunnel that we built between the hospital and the central utility plant. Once they got down there, none of their radios worked. We can solve it, and we're going to. There's a second tunnel that is planned as a connector between the new hospital building and the central utility plant. And so we've already spoken to the architects about making provision for that. But we need to systematically go through the campus and make sure that they can have adequate communication. We want them to be here to protect us and our patients when necessary. So we'll be working on some of those things. We learned a ton about exposure to radiation because that was part of the scenario. It was a dirty bomb. And I think everybody is going to be adding up the lessons learned. Once again, with multiple agencies involved in the drill, the biggest single problem was communication. And when they talk about what went wrong on the East Coast and what went wrong with Hurricane Katrina, that is the #1 problem that's been identified. And I don't know that I know how to fix it, but we can certainly take a look at how things happened here and try to improve them. That's a tough subject.
Thank you, Nancy. We'd now like to have our construction report from Ed Fan.
Thanks, Dr. Stewart. So I have a relatively brief report. We're online with a schedule that we've shared with the board in the past months. The news in terms of the pavilion or Morris Hyman Pavilion is that we are moving forward with finishing up the VE value engineering process and going out to bid with that work, and anticipating that we'll come to the board in the open session in July with bids at that time. In the meantime, we on the garage, we simply are moving forward with the permitting and planning commission stage. We've had our second comments from the Fremont building permit departments, and are just resubmitting those. At the same time, we're planning to go, or we're scheduled to go into the Planning Commission in May. We anticipate getting both approvals in May, and so we'll be going to bid earlier than that, since we feel like we've got a pretty good feel and history for what the comments are and what they're going to want there. So we very well could be getting bids back on both projects at about the same time. The main thing that's gone on in the last month has been demolition of the Whitaker Pavilion. So you've seen in the past the asbestos abatement that's gone on, and over the last 10 days, basically the building that was the Whitaker Pavilion is no more, The process, basically, it is a bit of a green process in that all the materials of the building are separated out, and then they are removed from the site and recycled in a variety of ways, with each material having a different process that they go through for recycling. And so this is while the building is down, we still have a fair amount of work to do, because all the concrete that is the pad of the building, the elevators, the tunnel underneath, all concrete, all has to be demolished. So while we've got a lot of the upfront or the visible work done, it's going to be noisy and dusty out there for the rest of the month. One of the things just to point out is that there was a gas line that was going through the site that the Whitaker Pavilion was on, and that the new building is going on. So we did do relocation through the tunnel of that gas line, and this will be the first of many utilities that will go through the tunnel that was completed at the with the central plant project. With that, we have Joe, if you could come up and prepare for our next presentation. Nancy will introduce the gentleman from Hensel Phelps that will show you a little bit of the BIM process that we're going through for the Morris Hyman Pavilion.
Before you do that?
Yeah.
What'd you do with the Whitaker Pavilion sign that was up there?
We have the Whitaker plaque that was put there in 1970. It's actually in my office.
Oh,
So we will be placing that somewhere where it's deserved on campus.
Given the importance of Whitaker to the history of this hospital, I think that at some point that's appropriate, we might
Sure.
want to consider a renaming opportunity. I'm pleased to introduce tonight the project superintendent from Hensel Phelps, Rob Wellner. He is a mechanical, electrical, and plumbing coordinator for this project. He's been working in the construction industry since he was 14 years old, helping his dad build and renovate houses in their neighborhood. And he graduated from North Dakota State University in 2002 with a construction management degree. He's worked for Hensel Phelps for more than 12 years. He's worked on a project in Colorado, another one in Southern California, and another one in Berlin, Germany. It must have been an interesting experience, so we'll have him make his presentation.
Thank you very much for the introduction. On behalf of Hensel Phelps, I'm here to present a brief overview of kind of our BIM process, and I'll kind of explain that with the support of Jacobs, the construction manager, as well. So just to kind of quick over the agenda, I'll just give you kind of an introduction of what BIM really means. Just kind of give you the background on the current project, and then just a little bit of a return on investment kind of overview of what we're actually looking for. So with that said, there's different elements to BIM. The main thing is, if you guys have probably seen just normal drawings that are 2D drawings, kind of hard to decipher and everything, and what we do is we put it into 3D. It's kind of like a video game, essentially. We're putting everything into something where you can move around and extrapolate kind of the good information to make it more usable, and so that everybody actually knows what's going on. There's other elements. There's 4D, which is actually linking that 3D model into time. So what we do is we actually create the schedule and put the schedule on top of it too, so you can actually, in the model, see exactly how the building's going to be built, and then go out and actually visually see it as well. 5D is a fairly newer one that actually puts cost into it, so you can actually do estimates on it. So if you decide to, change some walls around or some doors, or add a different office or whatever, we can actually kind of extrapolate that cost as well. And then 6D is more of linking the as-built model, so it's actually, for example, what this room would be, and trying to get all the facilities people to, understand what's going on. So there's a lot of little things that go on with everything, to make this building go on. So it just helps them to decipher that stuff much faster. So basically, BIM stands for Building Information Modeling. What that really is the more information that you have, the more accurate the model is going to be, the more accurate of what all this stuff is going to be. So it serves as a visualization and a coordination guideline. It really helps us to move forward and to build things more efficient, faster, on time and on budget, and those are kind of the big parts of it. So really the power of the benefits of it is the power of visualization. It kind of gives everybody the sense of the space and how everything's going to actually be used. One of the biggest things on there is actually the third from the bottom there, the first time mentality, the prefabrication part of it. The prefabrication part of it, to control quality, control time and everything else, the more information that we have and the more that we can do it at the shop, outside of the job site, the less noise we're making, the better quality control we can do, the more safety that we're actually accomplishing with it. And we just bring it on site, and it's basically like Legos, and so you just put everything kind of together and then do the last couple of checks and get OSHPA's approvals, and we're off and running. So basically a simplified product. So these are some of the past projects that we've worked on. This is just, this is a couple boilers. So this is like the central plant that was just built a few years ago, similar to that. We just kind of put everything in virtual, and then we put it in real life, and you can kind of see through the pictures it's the same thing. This next slide is kind of an office building, kind of similar to this project as well. So, above all these ceiling tiles, I mean, it just looks like, a couple lights, and, you're getting some air and everything. But above there's a whole bunch of stuff going on there, ductwork, electrical, to make everything comfortable for everybody as the end user. So just kind of showing that. And then this is just, all of this stuff on this slide was done through prefabrication. So everything here was done off-site, and all we did is brought it in and actually just put everything in there, and that saved a bunch of time and effort. So kind of like how the whole BIM process starts, all the way to the left, there's a little, it's kind of hard to read probably up there, but it starts at programming. You know, we get the end user agreement, understandings of what they actually want. We go to conceptual design, which is just kind of like deciding what it is. And as we go through it, we start working with the architect, kind of developing the drawings and getting everything up and running, go through fabrication, and then actually build the building. So just, this is kind of where we get into a little bit more interesting, I guess. There's a couple more graphics here. But this is more the excavation part of it. So right now, as Ed was indicating, we're demoing out the project right now. It'll be a flat dirt lot. And then from this, what we're going to do is dig this thing down. So what we're doing with this model essentially is making sure that our estimates are correct and making sure that we're taking out the correct amount of dirt off-site and keeping it on here. This is where we're putting in some concrete. So this is all the concrete foundation stuff. There's just a lot of different undulations and different things to it. This one, there's a whole bunch of little base isolators on there. So it's a different type of foundation with the OSHPD, you know, coming around. There's a lot of earthquake requirements that are required for this, and there's different foundation types, and this is one of them. So with this base isolator, and I'll get to this kind of picture right here. So basically this base isolator sits on a little pier, and what it does is there's a strut that's actually going through there. So when the buildings, you know, if there was an earthquake, what's happening is that the ground's actually moving, and for the most part, buildings always want to move with the ground. And in this scenario, if the earthquake actually goes, the building's slightly moving. It's not actually going to move all in parallel, so it's not actually going to want to topple over or do anything that's going to be different with it. So it's a very, very good foundation system that'll definitely keep the building up through an earthquake. So this is part of the 4D part of it, that scheduling aspect of it. As you can see, there's different colors that we kind of put onto this. It basically goes from red to white to gold to blue. So what we're kind of showing is progress as we're actually going through the model, which helps to explain where we're going with everything. So it's actually a pretty useful tool that we use for all the foremen and superintendents for them to really understand. Here's a kind of a virtual mock-up. So what we've been doing a lot with through Hensel Phelps, and I know as well Jacobs has been doing that, is we do a lot of virtual mock-ups. So we create this rendering of the mock-up room or a boardroom or whatever, you know, the owner actually physically wants. And what we do is we come out to this. So excuse me. So what we do is we create the model and actually decide if, you know, do you want your sharps dispenser here? Do you want your soap dispenser here? Do you want this outlet moved over to this location? And what we're trying to do is get the end user's agreement so that when we actually have to build it, we don't have to move it later on, which actually saves time and then also saves money as well. So that's kind of where we're going with it. So we've created a couple of them. Here's an ICU. So we're actually creating as much as we can until we actually get some of the subcontractors bought out. We don't have the exact equipment, but a lot of the subcontractors will create the exact things, right? The exact boom, the sharp dispenser, the TV, and those are the little things that, you know, matter to a lot of people, and it matters to us as well. And what we're trying to do is get it so that everybody's comfortable with where we're going with it. So here's just a quick little rendering of a med-surg room. We just kind of created a whole bunch of different, put in everything that's associated with it, so all the mechanical, electrical, and if you look closely, you can kind of see kind of the bed. We didn't want to make the video too long for everybody in here, since I'm sure the meeting will go along. So, but this is kind of where we're at with it. So. So some of the other stuff that we do is we have this other software called Navisworks that we actually go and detect where everything is going to be clashed or whatever. So we don't want a pipe or a ductwork actually touching themselves above the ceiling there. So what we do is we go through all these clash detections, and it's pretty intensive. We go through a lot of meetings and different things to try to get it so there's no clashes when we come out on site. So just kind of simplistic. And I'll go through this pretty quick, but here's some steel, so I'm just going to kind of put every element into it. So first we have steel, then we put in some exhaust duct, put in some return duct, put in the main supply, then we put in the branch supply ductwork, put in some conduit for telecom, put in some normal conduit, put in some telecom for, for your AV and like all that kind of stuff. Here's some fire sprinkler piping. Then we get into the supports part of it. So this is all the horizontal supports that we actually put in. And then this last slide right here is all the seismic stuff. So this is really what OSHPAD's all about. They really want to know, like, if you're in a specific bay, can that structure actually hold it in case there is an earthquake, that nothing's going to fall down and hurt anybody, especially patients, doctors, everything else that's going on with it. So what this does is it actually speeds up the process. It speeds up the process to get to the point where we actually know where everything's at, and then we come out there and everything runs very smooth. So the return on investment. So there's really the cost benefits. There's a lot of different studies that are being done out there. Essentially, unless you build one building exactly the same way as the other one with BIM and one without BIM, it's kind of hard to decipher what the true cost savings are. There's a lot smarter people out there than I am that disseminated that somewhere between 15 and 40%. There's a 15 to 40% saving on construction costs, and that's McGraw-Hill, who's a pretty reputable company out in New York. And then the Construction Industry Institute says there's about 3 to 7% if you do 3D coordination, which is all that stuff that's above the ceiling. So just as an example, on my last project, we just for a simple thing, after we got done doing all the coordination, we added over 500 beam penetrations in there to kind of save the ceilings and spaces, and we saved the owner over $200,000. So just a kind of quick give it to it. Another job we did down in Southern California, the subcontractors did pretty close to the same type of building, and they saw an increase of productivity in some of the ductwork for 20%, and reduction in plumbing manpower at 25%. So that's kind of the benefit of it. It's saving a lot of time and effort for it. So with that said, the other one last advantage is when this BIM model is all completed and everything, you can turn this over to another architect or engineer or whatever if you want to do TI spaces. So if you want to change something up in the future or whatever else, you do have that information. So any questions, comments, concerns? All right, perfect. Thank you very much.
Thank you. Nice to see that. It'd be better to see it up. Now I'd like to have our quality report from Barbara Eusebio.
Good evening. We're going to discuss a very serious healthcare matter called severe sepsis. Severe sepsis is a major complication and it can cause death. And the definition, is systemic inflammatory response syndrome caused by severe infection. Many lay people use the term blood poisoning. So it is a very serious infection. In fact, as of 2013, sepsis is the 10th leading cause of death in the United States, and more than 500 patients die of severe sepsis daily. The national sepsis mortality rate is between 40 and 60%. There are 4 evidence-based ways to improve the outcomes of sepsis. They include preventing it, getting early identification of the infection, early treatment, and then to monitor the outcomes and performance. So let's look at the progression of sepsis. It can start with a simple infection or a trauma, and it would be a mild reaction of the body to that event. But then it can quickly lead to that blood poisoning and the body's reaction to the serious infection. And then it can become severe, where the sepsis can then shut the organs down and literally bring the kidney to stop functioning. And then the patient can go into septic shock. That's when the blood pressure will drop and eventually may lead to death. This progression of sepsis can happen very quickly, within hours. So what are we doing about it? So in 2007, the Betty Moore Foundation selected us to be a pilot site to implement evidence-based practice for sepsis. The team included nurses, physicians, pharmacists, and other disciplines. We had two main goals. One was to improve our screening and identification so that with our bundle compliance, we would at least be 80%. If you can remember, in the past, I've talked about bundles, and I'll show you that in the next couple of slides, that there are a certain group of interventions that need to be done quickly. And then, of course, improve our outcomes. And although the nation is 40 to 60% mortality rate, Washington Hospital chose to be less than 30%. So early identification and treatment. As I previously said, there's a group of interventions, or a bundle, that need to be done within 3 hours of the patient coming to the emergency department, all within 1 hour in the intensive care unit. So what the medical staff has to do is look at the lactate level of the patient, draw some blood cultures, give antibiotics, fluids, and then also give drugs to help monitor and increase the blood pressure. There's a recent initiative that we participated in with the Alameda Emergency Medical Services and Highland Hospital. The study wanted to determine that if the EMS could identify sepsis in the field, would we have a better outcome? So we did work with the EMS, and we did pre-screening in the field before they got to the emergency room, so that the early phases of sepsis were identified, and then the emergency room could quickly stop that bundle. Because remember, they only have 3 hours from the identification of sepsis. And the data did show that our in-house mortality post-program went from 29% to 10%. And we also looked at pneumonia, and our pneumonia outcomes mortality went from 49% to 33%. Because pneumonia can also result in a sepsis. So what this chart shows you that when you have compliance, the blue line is compliance with that bundle. The better compliance we have with the bundle, the lower the mortality rate is. So this team is working very hard to make sure that that bundle rate stays above 80%. So what are we currently doing? So the Quality Improvement Initiative for Early Recognition and Treatment of Sepsis is now going to focus on the medical surgical units. We've done a lot of work in the emergency room and in the intensive care units, because a higher mortality rate is seen in med-surg units compared to the emergency department. So we have been accepted as one of 65 national participants in Surviving Sepsis Campaign Collaborative. This is supported by the Betty Moore Foundation. And our time period is from February 2014 to July 2015. As you can see, going back to 2008, we have taken our sepsis mortality from 33% to 21%. Remember, the national mortality for severe sepsis is 40 to 60%. So our next steps, we are going to continue to focus on the medical surgical units and identifying and treating sepsis. We will be looking at research publications and presentation of results of our program, and of course ongoing monitoring of performance over time and education efforts on appropriateness and benefits of tests. Thank you. Any questions? Okay,
Nope.
Thank you.
Thank you, Barbara. And Chris is already standing. We'll now have our finance report from Chris Henry.
Okay, tonight we'll be looking at the operational and financial results for Washington Hospital for February 2014. Move right into our operating indicators. Average daily census for February came in at 171. We expected 206.2. And we had 951 admissions against a budget of 1,021. And our patient days were 4,812. We'd expected 5,773. So census in February was pretty low. I mean, if we would have been looking at these numbers in July or August, we would have thought, okay, you know, that looks normal. But these are particularly low numbers for a February where we are generally running a very high census. Outpatient observation equivalent days for the month were 223. We'd expected 319. And our average length of stay for February was 5.16. We had expected 5.66. Moving into utilization, the case mix index for the month came in pretty close to budget at 1.524. We had 141 deliveries, 13 less than what we had expected for the month. Our surgical cases came in at 340. We had budgeted for 367. That included joint replacement cases that were 10 below budget at 112. We had 27 neurosurgical cases against a budget of 15. Our cardiac surgical cases landed at 9. We'd expected 12 for the month. Cath lab procedures for February came in 55 below budget at 336. We had 7,476 outpatient visits for the month, about 647 below the budget of 8,123, and those were primarily driven in the lab. The emergency room had 341 fewer visits than we had expected at 4,179. So a quick look at the cath lab activity for the month. Again, cardiac procedures for the month made up about 42% of the business. The rest, peripheral vascular and interventional radiology types of procedures. Moving into productivity, productive FTEs for the month were 115 below budget at 1,312.8. We had almost 150 non-productive FTEs for the month, giving us total FTEs that were 117.6 below budget at 1,462.4. So management was definitely trying to get folks out during this low census period. However, our FTEs per AOB, because of the really low activity, came in at 6.43. We'd expected just a tad less than 6. Moving into the numbers. First, we'll look at our Governmental Accounting Standards Board presentation, which is the presentation used for our audited financials. Total patient revenue for the month came in 13.5% below budget at $162,748,000. Our contractual write-offs for the month came in at 78.49%. We had expected 76.82%. We did have a high level of government payers, and we're seeing that continue in March. We had expected an increase of this, but it has increased actually a lot more than we anticipated in the budget. So we end up with net operating revenue about 19.5% below budget at $35,296,000. Operating expenses were $2.2 million below budget at $39,949,000. Those variances came in the area of salaries and wages with our lower FTEs. Benefits were below budget. Health and welfare claims generally drive that number, and we had lower than expected health and welfare claims in February. Supplies were below budget with our lower levels of activity. Purchase services and professional fees were also significantly below budget. It came in a number of areas, including community relations. The timing of our special care nursery opening was pushed out a month, so we had anticipated that hitting in February. It didn't hit till March. And we had lower medical services fees due to our lower ER activity in the month. Bad debt was also spiked up actually in the month. We have the last couple of months we've seen lower bad debt as our revenue was lower. But in February, we had 3 particularly large self-insured, out-of-country cases hit bad debt that amounted to about $1.5 million that we don't believe we will get paid for. So we ended February with an operating bottom line showing a loss of $4.653 million. Non-operating income for the month came in at $1,730,000, giving us total bottom line from a GASB perspective of a little bit over $2.9 million loss for the month. Quick look at our Financial Accounting Standards Board presentation. This is a representation of how the financial markets might look at us. That operating bottom line doesn't change it with a $4.6 million loss. We pull out our property tax revenue that's used to service our general obligation bonds and our small unrealized gain on investments to come up with non-operating income from a FASB perspective of $342,000 and a total bottom line showing a $4.3 million loss. So a challenging month for Washington Hospital in February. Are there any questions?
Okay. March is tough too. There are some positive trends which are hopeful, but it's very, very clear to anybody who's looking at our data this year that the world has changed, and so must we. So when I conclude with our March statistics report, I'll be introducing to you our representative from VHA who's going to discuss the project charter that we have commissioned VHA and Novia to execute here at our hospital, targeted to reduce expenditures for supplies and other areas of concern. Their project is an 18-month project, but it is already underway in some areas. It will also include the medical foundation and the surgery center. So it's going to have a significant impact here, I hope. In month, we saw 1,009 patient admissions. We had an average daily census of 161. This was 15.8% below the budgeted average daily census of 191. Our high and low census ranged from 180 down to 135. Outpatient observation equivalent days of 266 were lower than the budget of 407, which is a very positive trend for us, because those are days for which Medicare does not pay inpatient rates, but patients basically are receiving inpatient care. So to control those days is a singular objective of ours. Our average length of stay for adults and children in March was lower than budget. It came in at 5.08, and that's a good thing. The birthing center exceeded budget. They saw 167 deliveries in March. Their budget had been 161. We had newborns totaling of 170 in the month, so along the way we had some twins. For the month of March in surgery, we had 371 surgical cases, 3.6% below the budget. This includes cardiac surgical cases that were 6 below budget, neurosurgical cases that came in 15 above budget, and a joint replacement cases that were right on budget. So the neurosurgical part of our surgery volume is really holding its own. When we look at surgical minutes that drive operating room charges, historically under percent of charges kinds of contracts, we did come in below budget. And I don't know that that's necessarily going to be a bad thing when we move, as we will and have discussed, to a different basis of contracting, where percent of charges, having a high number of minutes is a good thing. And in the other direction, where not necessarily so. We had 603 cases seen at the outpatient surgery center versus a budget of 543, so they came in above budget. The cath lab came in above budget. They had 389 cases, and we had budgeted 388, so we got one case above, which is a good trend given what's been going on in recent months. Interventional radiology procedures were 9 above budget. PTCAs were above budget as well, and cardiac cath procedures themselves came in below budget by 20 cases. Overall, we had 34 more cases than anticipated, so it's a 21.7% positive variance. Outpatient procedures came in under expectation by 33 cases. Non-emergency outpatient visits were 8% lower than the budget of 8,640. They came in at 7,951. This included clinical lab visits that were 26% below budget, offset somewhat by x-ray visits that were above budget by 16.7%. Emergency room recorded a total of 4,481 patients for a daily average of 145, and this was below our budget by 2.8%. Washington, Warm Springs, Newark, and Nakamura and Ohlone clinics saw approximately 4,342 patients during March, 7.2% more than the budget. The total system emergency room and clinic visits for March were 8,823 compared to a budget of 8,660. In terms of full-time equivalents for the month of March, we had 1,427.2. 17.9 were agency personnel. This was 16.6 FTEs lower than the budget. The FTEs per adjusted occupied bed came in at 6.59, which is above the budget. Productive FTEs were below budget by 19.7. Our patient mix preliminary information indicates that inpatient revenue for the month of March amounted to approximately $127.3 million. We had budgeted $150.8 million. Of this amount, 59.7% was Medicare, including the Medicare HMO, and 18.7% was Medi-Cal, including the Medi-Cal HMO. We had budgeted inpatient revenue at 56.1% for Medicare sponsored patients and 16.6% for Medi-Cal. Our total government program revenue for March was 78.4%. That's not good because, as everybody knows and understands, the government pays far less than the full cost of care. This is a bad trend. We had budgeted it at 72.7%. Based on March's 4,997 patient days, 58.1% were Medicare, including Medicare HMO. Okay, we just did that. I wanted to mention that in looking at the other sponsors in payment of care, private pay was budgeted at 4.5% of our revenue, and it came in at 2.3%. PPO was 17.1%. Our budget had called for 18.5%. HMO was budgeted at 4.3% and came in at 2.3%. So we're seeing more erosion in HMO, less in PPO. Let's see. March had 40 fewer admissions and 938 fewer inpatient days than anticipated in the budget. Surgical cases come in below budget by 14. Cath lab procedures come in above budget by 1. Outpatient visits are below budget, and ER visits were lower than anticipated. Clinic visits for the month were above budget by 290. 7.2% positive variance. Total paid FTEs were below budget by 16.6. Inpatient charges for the month were lower than budget by 15.5%. Outpatient charges were lower than budget by 5%. On March 31st, there were 154 days cash on hand, up from the previous month. The total days revenue and accounts receivable at March 31st was 65.7. The days revenue and accounts receivable excluding Medi-Cal was 62.6. During the month of March, $1,691,666 of charges were approved or pending for charity assistance. I know that in Chris Henry's presentation about large accounts that had to be written off, about foreign nationals arriving and receiving free care, that we have one more very large account of an individual yet to be discharged that will fall into the same category this month. It will be $1 million write-off. I don't know what the solution to this is. I don't know that the government has any will to address it, but it is a huge problem for us. And when you look at what that costs the hospital over the course of a year, it is a significant problem. And I don't know if our elected representatives are willing to step up. I want to introduce VHA so that everybody understands who they are and what they're doing here. They deliver industry-leading supply chain management services, clinical improvement services, and they facilitate the development of their member networks. It brings people from hospitals together to solve clinical and operational challenges that drive sustainable results. VHA serves more than 1,350 not-for-profit hospitals and more than 72,000 non-acute healthcare facilities in all 50 states and the District of Columbia. VHA's membership includes approximately 28% of the nation's community-owned not-for-profit hospitals. Novation is the enterprise's supply chain company, and it is jointly owned by VHA and UHC. Novation is a leading healthcare supply chain expertise, analytics, and contracting company for the more than 100,000 members of VHA Incorporated. Novation provides alliance members with sourcing services as well as information and data services. They're based in Irving, Texas. Novation develops and manages competitive contracts with more than 600 suppliers. Tonight, we're going to introduce you to Randy Medwood. She's the Senior Director for Performance Services of VHA, and she provides us with strategic counsel and direction, seeking to help us optimize healthcare value equation, improving or maintaining outcomes while decreasing costs. For larger engagements with members, she adds the value by overseeing the engagement, serving as the key liaison between clients and their desired deliverables and the project team. As a senior director of the practice's project management office, she's responsible for the overall performance monitoring of the practice's project portfolio. She's going to be with us over the course of the next 18 months as we begin to look at our supply chain. We have already had an important meeting with all of the medical directors this week, where they were introduced to this project and have the very clear understanding that we're going to be moving aggressively to standardization, and there will be reduced choices, and we'll gain a tremendous advantage financially by not having every and any suture and every and any catheter, and so on and so forth. But I would like her to present to you on our project.
Thank you. Good evening. I appreciate you welcoming us into your home for the next 18 months. We are very privileged to be part of this organization and helping you through this endeavor. So with that, I just kind of want to take you through a little bit of a high-level overview of our project. We'll talk about the project scope, some of the project oversight and controls that we'll have in place to make sure that things function really well. We'll show you what our project team roster is. We will have a plethora of people that will be coming on site to help you through this process. It's not just behind the scenes, it's with you, holding your hand, helping you through the process every step of the way until we get to our goals. Give you some cost tracking lessons and put some tools in place so that you have a sustainable process through moving this forward. As Nancy said, this is 18 months, but we want to make sure we leave you with some things behind that you can do this on your own once this portion of the VHA relationship comes to a conclusion, and that's the consulting piece. Some status reporting and some next steps. So with that, this is a $5 million non-salary cost reduction initiative. It's annualized implemented savings. So when we talk about implemented, means that you will actually put them into place and make the changes, whether they're from product or their pricing, utilization, standardization. You'll actually make those changes and you'll see those dollars flow to your bottom line. The timeline is 18 months. It actually began as of February 1st. We have been here. We did a kickoff a couple weeks ago, so we've started that process. We've started the data collection process. So things are going on, even though we might not be fully engaged from a people perspective. There's a lot of things going on behind the scenes. I also have with me in the audience our project manager, Marcia Lewis, and Marcia will be your project manager, and she'll be here almost every week, at least for the first 3 to 6 months. And then after that, we'll determine what the needs are, but there will always be people that will be engaged with this process. We want to make sure that, like we said, give you some methodologies that we leave behind, and they're cost reduction processes. We bring in national experts. The people, our subject matter experts that we bring in here are people that have done the same work. They're not just people that think about in theory. They are cardiology directors. They might be surgical OR nurses. They have lived and breathed it from the hospital side, and we make sure we bring those right people in to help work through those initiatives. We implement what we call clinical quality value analysis, and we've trademarked that name, but really what that is, it's a process to help your organization determine what are the best products to use in your hospital and make some changes and make some decisions. So those decisions are not just made by one individual. We put a process into place that those decisions are made by a team. And when people have requests for new items, or you have a physician who needs something new, there's a process in place to help drive those decisions and make the right decisions for your organization. We bring in special people around custom contracting. So when you start looking at price for some of your physicians' preference items, we help them drive some of those best practice pricing and benchmarks so that you're getting the products that you're using here for the best price for this hospital, and try and eliminate any, or I should say just put some transparency out there in pricing so that everybody is really understanding of what you're paying compared to everybody else in the country. We do purchase services. A lot of our efforts are around purchase services, looking at contracts and the types of contracts for those types of services. Might be food services, environmental services, dialysis. There could be a whole other area of purchase services contracts we look at, but we make sure we want to go there too. We bring something called Price Links, which is a data benchmarking or price benchmarking tool that we will leave behind, and people in the organization will be trained on how to use it. So if you want to look at a particular product and you want to look at what the 5th, 10th, 25th, 50th percentile benchmark prices on that, you will be able to see that through this tool, and then you'll be able to go to your vendors and work better with your vendors on those pricings. We work with some regional offices, our folks from VHA West Coast, and our regional office, which is in Dallas. But really what we're looking for is a long-term success. We really want to make sure, again, like I said, that we leave you with a sustainable process. We are a partner with Washington Hospital. We are not just here really for the 18 months. As your business partner that came on board about 2 years ago, we are here for the long haul, and we want to make sure that, that you are here for the long haul too, and that you're very relevant in your community. So some of the things that we work on, this is just some of the project scope. We touch everything that we call non-salary. So it's really all about the stuff. And that includes all your physician preference items, supply chain items, pharmacy. We bring in a pharmacy SME to work with your pharmacy staff as well as your physicians to look at medication usage, utilization. We look at contracts, we look at commitment levels, again, we look at purchase services. But a lot of the work really focus on very heavily in that physician preference item in that first category, because that's really where the biggest opportunities typically lay. This is just a little high-level oversight of our timeline. We are very project management process-oriented, so we follow this process we go through an assessment phase, which started, again, the beginning of March, and we'll gather all your data. We start looking at recommendations, and we work with your organization, with your staff, with your clinical quality value analysis teams to make some recommendations on what we think you could do, and then we work with you to implement those. It's not just handing you a list and saying, here you go, have at it. It's really bringing our subject matter experts in, sitting side by side, negotiating contracts, negotiating prices, giving you methodologies to make those changes in practice patterns or utilization, and again, getting it actually into place, because the goal of this is to realize those savings to your bottom line. We do measurement. We want to give you something, again, so you can measure your success, and then those tools to sustain. And why it looks like a linear timeline, it's really kind of cyclical because it's repetitive. Why we might do some of this analysis and recommendation very heavily on the front end in the next probably 3 to 6 months. As we go through the next 18 months, as we continue to find other opportunities, we'll bring those to your attention, and we'll bring those through the process again until we hit the goal. And our goal is typically to overachieve. $5 million might seem like a lot, but we know that if we can overachieve that goal, that really is what our intent is. This is just a little about our clinical quality value analysis. And this is really just to show you again that it is a continuous improvement cycle. It really engages your staff to be part of this decision-making process. It engages your physicians and your leadership. It requires active participation. It's not just people that can just sit behind their desks. They're really going to have to come to meetings. They're going to have to participate in evaluations. They're going to have to get in front of your physicians to have those discussions. So it really does bring this in as an organizational approach, not just driven by supply chain or a couple of key people in your organization. It also helps to send that consistent message back to your staff. There's nothing more important than letting everybody in your organization know how important this initiative is, and that it's not just about today, it's about the long term, because that's what's going to keep you relevant and alive in your community. And the last bullet here is just about aligning interests of your physicians with the hospitals and the vendors. That's something that in the past has been very difficult to accomplish. But in today's age, with the right process in place, and we have found with clinical quality value analysis, that you can truly do that. And you can kind of get everybody on the same page, and everybody's interest aligns. You get your physicians engaged, you give them the right information, and with them you work to getting to some of the best pricing that you can for your organization. This just kind of compares what we do. We have for every key stakeholder or every subject matter expert that VHA has, we also have a counterpart in Washington Hospital, and you can kind of see the list. I will serve in the capacity of executive oversight along with Ed, and then our project manager, Marsha Lewis, will work in concert with Lisa Sharp. And then everybody else in their areas of expertise has their key stakeholders or their counterparts. So we work very tightly with your organization to make sure that you're successful. And it's by the connection with the people that do the work day in and day out that makes it successful. Because if we just sat here and said, you need to do this and you need to do that, you're not going to be successful. It needs buy-in. This is just an example of the starting of what we call a project oversight and tracking tool. It will be delivered on a monthly basis to Ed as a project sponsor. He can share that with you, the board, and anyone else in the organization that would like to see this. But this will show you on a monthly basis where we are to the goal, how much we've identified, how many initiatives are there, and by the end of this project, there'll be probably a couple hundred initiatives out there, and it'll show you your totals all the way out. We'll leave this behind with you so you can continue doing that on your own if you so choose. So some of the next steps has really been around building awareness. We had a kickoff a couple weeks ago with your leadership team, with all your department managers. This is the next step in helping build awareness. We want to make sure that everyone in this facility knows that this is an ongoing process. As Nancy mentioned, our business partner, Novia, is also in your organization now doing some work around case management and care redesign. I believe that there's a presentation going on next week to kind of vet out what their initial findings are. I haven't seen that myself, but there's a lot of work that's going on between VHA and our Novia counterparts to look at opportunities to help your organization improve and save money. I will make sure that we give you the regular status reports. And we really want to celebrate successes because we have found that over the years, and we've been doing this a very long time, that the only way you really can sustain the ongoing process is people have to know that what they've done, the hard work that they put into it is appreciated, and so we try and make sure that we celebrate those successes. So the more that you can kind of help us communicate that message out to your counterparts, physicians, other people that you know in this organization, that this is an ongoing project for the next 18 months, we'd appreciate your support. Questions?
Yes.
Yes, sir.
How do you deal with the rate volume changes? I assume your $5 million is determined, or it's a function of some volume level of business. So how do you deal with that if volume levels are either up or down with respect to your $5 million?
Absolutely. Good question. We start with a baseline, obviously, and the data that we pull currently is based on what your volumes have been in the last 12 months. And then we look at those, and depending upon the type of initiative it is, it may be more impactful and more driven by a significant change in volume. Unfortunately, we don't know what's going to happen in the future. We can only really look at what's happening in the snapshot in time and drive the savings around those. But the intent, in most cases, we find that the savings estimates we may project today are probably on the low side, and over time, again, based on volume and certain other criteria, your savings typically winds up to be greater than, but I haven't quite figured out a way yet to really predict how much your volumes are going to shift in the future.
So it is based on current
It is.
numbers.
There are some cases where there might be a remeasurement further down the line. I think that some of that may happen on the care management and the case management and care redesign, that there might be some remeasurement later on to really see how the savings have been effectuated based on changes in volume. But you have to start with a base point, and hopefully your volumes in that particular service line won't shift dramatically to really negatively impact your savings. Any other questions?
Appears not. Thank you.
Great, thank you.
We'll be cheering on for overachieving.
Absolutely, us too. Thank you.
Thank you. We have some action items we need to consider this evening. Action item A, hear that from Dr. Nichols.
Mr. President, in accordance with district law, policies, and procedures, I move the Chief Executive Officer be authorized to proceed with the purchase of Medline cubicle curtains for an amount not to exceed $79,754. This purchase was not included in the fiscal year 2013-2014 capital budget.
Do we have a second? We have a motion and a second. Nancy, would you like to explain that a little bit more to the public?
Yes, I would be happy to. We are honing in with significant focus on the incidence of infectious disease, and in particular C. difficile. And it is a very contagious and debilitating infectious disease. And we are in the process of a far more proactive approach to the physical environment that patients are in. And what we would like to do is improve the inventory of curtains in the room and change them out far more frequently. In particular, would be mandatory exchange when we're taking on a room where the patient was in isolation, and certainly a greater frequency for patients who are not in isolation as part of this whole effort. The curtains we're purchasing are fire retardant, and they are made with antimicrobial agents infused in the fabric. That should help us significantly with eradicating infectious microorganisms. The cost to purchase 660 cubicle curtains for the entire hospital is the $79,000 figure. I spoke with Ed. We will pull other things out of the capital budget that would have been purchased this year to cover it. But we need the permission of the board because it was not in the original budget.
Catherine, if you'd like to call a vote on that item A.
Yes, Director Stewart.
Aye.
Director Wallace.
Aye.
Director Nicholson.
Aye.
Director Dennison.
Aye.
Director Eben.
Motion passes. We'll move now to item B.
Item B, Mr. President, in accordance with district law, policies, and procedures, I move the Chief Executive Officer be authorized to proceed with the purchase of 2 Gatinga washer disinfectors for the sterile processing department for an amount not to exceed $78,727. This purchase was included in the fiscal year 2014 capital equipment budget.
Second.
I have a motion and a second. Nancy, again, on that
We
item.
currently have 3 washers in our sterile processing department, and this request would replace 2 of them, which were purchased in 2004. And 10 years is a long time for this kind of piece of equipment. They're used continuously to wash and disinfect instruments. They are never not being used during the day. These 2 washers are also used for the orthopedic instruments that are needed for Dearborn and Saw, and they have some very busy surgical days. According to our records kept by Biomedical Engineering, there have been 97 service calls for both washers, 17 in the last 12 months. One or the other of the washers is out of service every week. The downtime is a problem for this department, keeping up with the demand. This is a purchase that was included in the capital equipment budget.
Catherine.
Director Stewart.
Aye.
Director Wallace.
Aye.
Director Nicholson.
Aye.
Director Dennison.
Aye.
Director Eben.
Aye.
Motion. That item passes. We'll now move on to item C.
Item C, Mr. President, in accordance with district law, policies, and procedures, I move the Chief Executive Officer be authorized to proceed with the purchase of 9 digital copy machines for the emergency department, cast room, respiratory care unit, women's imaging library, pre-op testing area, storeroom, community resource library, cath lab, information services, and foundation for an amount not to exceed $45,463. This purchase was included in the fiscal year 2014 fixed asset capital budget.
Second.
I have a motion and a second. Again, Nancy.
I guess the simple explanation is that these 9 copiers are all 8 to 10 years old.
It's a long time for a copier. Anyway, good. Catherine?
Okay. Director Stewart.
Aye.
Director Dennison.
Aye.
Director Eben.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye. You changed it up that time.
She's trying to keep us awake. Anyway, I appreciate you doing that. That item passes. Item D.
Oh dear. Mr. President, in accordance with district law, policies, and procedures, I move for the adoption of resolution number 1144, which calls for the district general election to be held in Washington Township Healthcare District on November 14th, 2014, for the election of 3 board members, each for year terms.
I think that's November 4th.
Did I say 4?
14th, yeah.
I think you said.
November 4th.
I think you said 14.
Oh, okay.
We could take it any time.
You'd just as soon not have it.
That's exactly right.
Second.
We have a motion and a second. This is for the election of 3 board members. It comes around every 4 years. And,
This is a mandatory action for the
this
board.
is the way it is. Catherine, if you'd like to call the roll.
Dr. Stewart,
Aye.
Dr. Wallace,
Aye.
Dr. Nicholson,
Aye.
Dr. Danielson,
Aye.
Dr. Eaton.
Aye.
Thank you. That motion, item passes. Item E.
Okay, Mr. President, in accordance with district law, policies, and procedures, I move for the adoption of resolution number 1145, which calls for the consolidation of the Washington Township Healthcare District election with the statewide general election on November 4th, 2014.
Second.
Have a motion and a second on this item. This saves the district a lot of money to consolidate the election, and it's an important election to have. Catherine?
Dr. Stewart,
Aye.
Dr. Wallace,
Aye.
Dr. Nicholson,
Aye.
Dr. Danielson,
Aye.
Dr. Eaton.
Aye.
That item passes. That completes our action items and our agenda for the open session. We'll now adjourn to a closed session. Thank you for your attendance tonight. We reconvene to our open session, announce that no action was taken during the closed session. There being no further business to be brought before us tonight, this meeting is adjourned. Thank you.